Hello, everyone, and welcome to the AMCI E&M series. We've designed this series to break down the E&M guidelines into manageable, digestible nuggets to ensure that you have the best possible learning experience. We encourage you to watch the playbacks as many times as you need until you fully grasp those guidelines. And if you're seeking CEUs, simply click the link in the description to enroll in our online course. All right, that was kind of rude. If you didn't know, I'm Mrs. J, the Curriculum Director at AMCI, and I'm absolutely thrilled to be here with you today. Now, let's go ahead and let's take a moment to introduce our fantastic team. And we're going to start with Miss Tamika. She is our Assistant Curriculum Director and Resident QHP. Yes, she is a physician's assistant. Now let's turn our attention to Mr. Sandeep, who is also a lead instructor at AMCI, and he is our resident pharmacist with a master's in pharmacy. And introducing our dedicated AMCI approved interns, Miss Dolly, who holds both CPCA and CCS certifications. And last but not least, Miss Jasmeet, who has an MS and a medical background as a CNA. And with such an incredible team by our side, we are excited to dive into these E&M guidelines together. So without further ado, let's get started on this journey. And this is a 4-part E&M series. Yes, we will discuss in part 1 the AMCI annotation technique called CHUN. We're going to teach you how to CHUN your E&M section. We're also going to learn to code office visits and scoring the medical decision making in part 1. In part 2, we're going to discuss inpatient coding, hospital observation. We're also going to talk about consultations and emergency departments. Part 3, we're going to talk about nursing facility visits, prolonged services. And part 4, this is where we're going to summarize all of it and we're going to test your knowledge. But rest assured, throughout the parts, we will be testing your knowledge. And finally, keep in mind that we will consider the 2023 guidelines and apply them every step of the way. Now, let's get this started. Let's begin with the copyright. CPT is copyright 2023 AMA. CPC is a registered trademark of AAPC. Keyword concept, FTR, CHUN, AMCI Fab 7 Flip Tap, and MCG are all trademarks of AMCI. And last but not least, the credentials, CCA, CCS, CCSP, RHIT, RHIA are all owned by AHIMA. All right. All right, so let's go ahead and review the topics. Last week, that's week 1, we reviewed CHUN. We learned how to code office visits and scoring the MDM. This week, week 2, we're going to take a deep dive into the 2023 changes on hospitals, observations, ED consultations, and nursing facilities. All right, everybody, let's get into it. But before we can, we have to know our texts and our tools. And this is just a review of what we discussed last time. You'll need your 2023 CPT manual. And if you have that little companion, it is excellent. It'll help clarify some of the guidelines. Also, the AMA CPT guidelines handout. This is published by AMA. And if you don't have the 2023 manual, definitely use this handout. It's also in your online course. And finally, if you have the MCG manual, this is an excellent tool. So definitely use it. It's not required, it is optional. And don't forget those writing tools. Now, let's talk about the goals of the presentation. Number one, we're going to discuss hospital visits. Number two, ED. Three, consultations. And we're going to talk about nursing visits too, if we have enough time. And we're going to talk about those 2023 changes. When we speak about office visits under that category, we're going to talk about inpatient hospital and observations. Did I say office visits? I mean hospital visits. We're going to talk about inpatient hospital and observations, same day admissions and discharges on the same day, and discharges. We're going to discuss emergency department guidelines as well as consultation guidelines. And if we have enough time, we're going to discuss nursing facilities. Hopefully we will. All right, so just so you know, we will be using the AMCI PDR chart, and the PDR chart is going to have a little different look. In the right-hand corner, we've added the codes for hospital, observation, consultations, nursing facilities, and home visits. So this will be very helpful for today's presentation. While you don't have this, this is a chart that we are developing for 2024, and this is kind of a beta. So hopefully you will understand, and if you want to put or document your codes, feel free to do so. All right, and so don't forget the key to success when you are scoring the MDM is understanding the definitions. Again, your handout, we have a link in the chat, and we also have a link in your online course. So definitely grab it. Study those definitions. All right, so now we have a general coding guideline review. Ready? All right, I have it set up like it's a game, but it's really not a game. But hey, whatever works, let's do it. All right, so let's play. Let's play. Finish the general E&M guideline. All right, you ready? When advanced practice nurses and physicians assistants are working with physicians, they are considered as working in the exact same blank and blank as the physician. All right, type your answers in the chat. What say you? I'll give you a moment or two. All right, so how did you do? If you said working in the exact same specialty and subspecialty as the physician, outstanding. Indeed, remember the guideline because it's going to be applicable throughout our discussions tonight. All right, we got another one. Let's play. Finish the general E&M guideline. In the instance where a physician or other qualified healthcare professional is on call for or blank blank, another physician or other qualified healthcare professional, the patient's encounter would be classified as it would have been by the physician or other qualified healthcare professional who is not available. All right, this one might be a little more difficult, but I think you can do it. Please go ahead, type your answers in the chat. All right. Now, I got to tell you, I can't see the chat. I know those answers are flying through. So, if you said covering for outstanding. Okay, I got one more. Finish the disclaimer. Although CMS guidelines will be highly pertinent to this instruction, we are only discussing blank guidelines to ensure that we provide a good foundation of the guidelines. Go ahead, type your answers in the chat. Okay, I know it's rolling through if you said CPT outstanding. All right, so yes, we will only be discussing CPT guidance. So, just understand that when that time comes, and it's going to come, I promise you, that there's been a CMS ruling. Don't worry. We understand the CMS ruling, but we are only discussing the CPT guidelines. All right, let's get started. And we're going to talk first about hospital or observation visits. Code series 99221 through 99233. And last week I mentioned, or last time, depending upon when you're viewing, I mentioned that the guidelines in the green pages that precede the E and M codes, the ones in the green pages, they're all applicable to office or other outpatient services, hospital inpatient and observation care services, consultations, emergency departments, nursing facilities, home or residence services, prolonged services. Yeah. So that is what these guidelines pertain to. So it's important that we discuss all of these subjects. We've already discussed office. Now we're going to discuss hospitals, consultations, ED, nursing facilities in this presentation. So let's get started with the guideline. All right. So here are some basic things that you need to understand when coding initial and subsequent hospital, inpatient, and observation care services. Well, just know that these codes in this section pertain to initial and subsequent E&M services provided to hospital inpatient visits and to patients who are designated as hospital outpatient observation status. And these codes are also used to report partial hospitalization services. And that is one of the biggest changes in the E&M section. The observation care services, pretty much those codes have been done away with, and they have combined hospital inpatient and observation care. So that's your first guideline. Just know that it combines two. Now, for patients designated or admitted in observation status, that is a patient classification. When you hear the term status, it's a patient classification. It's not a location in a facility, okay? Even though a lot of facilities or hospitals or ED have observation departments, but the classification has no bearing on the location. And that's what that guideline means. And also, when it comes to total time on the date of the encounter, it is determined by the calendar date. If the encounter spans 2 calendar dates, it is considered a single service, and you are to report one date. Now, I know some of you might be saying, hey, well, CMS, that's right, but we're only talking about these guidelines. We're interpreting CPT guidelines. So I'll say that again. Total time is determined by the calendar date. If an encounter spans 2 calendar dates, it's considered a single service and reported with one date. And finally, when you are documenting time, always use the total time, even when the encounter is continuous through midnight. All right. Now we've got some more guidelines, and these guidelines pertain to initial and subsequent services. Now, the first guideline, the initial visit is the first patient visit by a member of a solo or group practice during an inpatient stay. I'm going to say that again. The initial visit is the first patient visit by a member of a solo or group practice during an inpatient stay. It is no longer only for the admitting physician. That is a huge guideline change for 2023. Now, your subsequent visits, these are visits after the initial by any member of a solo or group practice during an inpatient stay. And covering for, and I think you all know that because you all demonstrated this guideline, and these are similar to just the general E&M guidance on initial and subsequent visits, but covering for provider who is covering for another will have the same exact status as the provider who is not available or who they're covering for. Physician assistants and advanced practice nurses have the exact same specialty and subspecialty when working with physicians. And if you are writing these guidelines down, don't worry. The handout is in your course. All right, so the handout will be next to the playback, so don't worry. Now, let's continue our discussion, and we're going to talk about the initial hospital inpatient or observation care. Now, this is the section of the guidelines that's right or directly above the codes. So we're not being repetitive, but some of the guidelines are. But just know that first visit is that initial visit is the first visit per solo or group practice of the same specialty and subspecialty per stay. So it's based on the practice. So if a doctor belongs to a practice, and a lot of them do, most of them do, either you're solo or group. Solo means that you're by yourself. Group is if you're in a group. Whoever comes in that practice, whoever comes in first, that's the first visit. All others are secondary. All right, so we established that. That's going to play, you're going to hear that a lot today. And you know what? That's my only goal for you today, to understand that guideline. That's it. All right, so when you have a newborn, for admission services for neonates, that's 28 days of age or younger, See the newborn code 99477. Now let's get to the good stuff. Another biggie change for 2023. When the patient is admitted to the hospital, and if an E&M visit results in an admission to the hospital, let's say a person is in the ED, and that ED admission results in them being admitted inpatient, you can go ahead and code that ED visits. You can code ED visits, office visits, nursing facility services in the setting of an admission into the hospital. You just have to report modifier 25 to that visit. So the visit, not the admission visit, but the other E&M visit. Now let's talk about consultations. If a consultant has already seen a patient at a separate prior location and then sees the patient again in the hospital as an initial hospital visit, do not code that hospital visit as initial. Use subsequent visit codes. And I know that's a mouthful, but we are going to revisit this when we get to the consultation section. But I just want to let you know that there are guidelines for inpatient visits as they pertain to consultations. Also, if a consultation is carried out after another doctor admits the patient, report subsequent codes. So I'm going to clarify that. And if a patient is transferred from observation to inpatient, it's considered the same stay. Of course it is, because an inpatient, hospital, or observation care, they're in one classification now. Okay, and I call it HIO. Now, let's go ahead and CHUN hospital inpatient or observation services. All right, so at the top, 99221. We'll begin at the beginning. And 99221 is an initial hospital inpatient or observation care per day for the evaluation and management of a patient, which requires a medically appropriate history and/or exam and straightforward or low-level medical decision. All right, so in addition to the MDM being straightforward or low, 40 minutes must be met or exceeded. That's important. That's another change. They are specifically saying that you have to at least have 40 minutes and or exceed 40 minutes. That's important because now you know when you can use 99222. So let's go ahead and document. I'm going to notate straightforward or low MDM 40 minutes on the left. Now 99222, this is moderate level MDM, and 55 minutes must be met or exceeded. So you see the difference between 40 minutes and 55 minutes? That's excellent. I'm glad they did this because now you know definitively which code to use. So if it's 47 minutes, you know you're using 99221. Previously, it wasn't that easy. And I'm documenting moderate MDM 55 minutes on the left. Now 99223. This is high MDM with 75 minutes that must be met or exceeded, and below. For services of 90 minutes or longer, use prolonged services code 99418. This is also new. There was no prolonged services code for inpatient encounters. Well, there was. Yeah, there was, but Now, we'll talk later about prolonged services, but just know we have a new prolonged services code for inpatient encounters. Now let's look at subsequent hospital or observation care. 99231. Use this code for straightforward or low MDM. 25 minutes must be met or exceeded. 99232, moderate level of medical decision making. 35 minutes must be met or exceeded. And 99233, high level of MDM. 50 minutes must be met or exceeded and below. For services of 65 minutes or longer, use code 99418 for prolonged services. All right. There's an FTR. We at AMCI call FTR guidelines, and we place them at the bottom of our CPT pages where the codes are. And the FTR that I've placed here was FTR, initial visit, report once per practice. This is the first hospital visit per group practice per stay. Code also certain visits such as office visits, ED visits, nursing visits that result in admission, and use modifier 25. Now, are you ready to test your knowledge? All right, so if you can recall, last week, we talked about whenever you are using total time to determine the level of service, make sure that the physician or qualified healthcare provider activities are present in your documentation and you're good. We're not going to review it because it would be redundant. But we will review the key words that you should highlight for your documentation, the age of the patient, any diagnoses, signs and symptoms, any exams that took place, procedures, or anything the doctor did, total time of the encounter, medical decision making, and oh yeah, the data reviewed. And we need to highlight that. Why are we highlighting it? Because we have to be able to answer these questions. Did a history or exam take place? What is the location of the visit? And when we mean location, well, when we say location, we mean the location of the encounter in your CPT manual E&M section. Yes. So I know you all might say, well, what do you mean? I'm going to tell you about it a little later. All right, so the type of visit, is it new, initial, established, or subsequent? Total time of the encounter, we need to know if the doctor documents that total time, that's fair, that's good. If not, we're going to have to know what the medical decision making is. If the doctor doesn't specify the medical decision making, we'll inventory then score and determine the level of service. We'll use the E&M tables to select the code. And then finally, we will apply all guidelines. And yes, this is the nature of our discussion today. Guidelines, guidelines, and more guidelines. All right, so without further ado, I'm going to ask Ms. Tamika to come to the fore. Take it away, Ms. Tamika.
Thank you, Mrs. J. And coders, I know you're ready for our first scenario for this evening. Of the following, which best describes Dr. Milton's services? A, 99221, 99215 with a 25 modifier. B, 99215, C, 99223, or D, 99232 with 99215 and a 25 modifier. Office visit. Sarah arrived at her PCP, Dr. Milton's office, with complaints of chest pain, heart palpitations, and profuse sweating. The doctor carried out a limited exam, then read the results of the patient's EKG. The results were inconclusive. However, Dr. Milton believed the patient may be having an AMI. The doctor was concerned that the patient may need immediate intervention that he was not equipped to handle in the office and had the patient transported to the hospital, where the hospitalist confirmed an AMI, rushed the patient to the OR, where the cardiac team carried out a PCI. Then the hospitalist admitted the patient after surgery. Dr. Milton visited the patient in the hospital for the first time after doing rounds and spent time evaluating the patient, conferring with the patient and family about restrictions status post stent placement, and requesting a cardiac consultation. The total time of the inpatient visit was 40 minutes. Again, of the following, which best describes Dr. Milton's services? Okay, coders, you have 2 minutes to solve. Please solve the scenario and place your answer in the comments or chat. Your time begins now.
All right, how did you do? Chat, I hope you are shouting them out in that chat. Well, not chat. Team, are you shouting out those coders in the chat? I hope so, because I know you are rocking it. I just do. It's difficult for me to see, so I'm just going to go ahead and teach. All right, so my keywords, we're going to begin with that. Dr. Milton's office, chest pain, palpitations, profuse sweating, limited cardiac exam, results of the patient EKG, AMI, hospital is confirmed in AMI, OR, PCI, admitted the patient. Dr. Milton visited the patient in the hospital, 40 minutes. All right. So we need to know. Well, we are tasked with coding for Dr. Milton's services. So what did Dr. Milton do? Where did Dr. Milton visit, or where did the patient, or where did the Dr. Milton see the patient? Well, it says that one visit was at Dr. Milton's office and the other in the hospital. All right? So office visit and hospital visit. So the nature of this discussion is it's guidelines and guideline applications. So I'm going to ask, are there any guidelines pertinent to this scenario that we need to apply? And if you said, yes, there's a guideline that says when a patient is admitted to the hospital as an inpatient in the setting of another service such as an office visit, the services in the initial site, in our case office visit, can be separately reported and to append modifier 25. So that means that we can code both visits and on site. If you can look at A through D, B and C are only coding for one visit, right? And we can deduce that the office visit is 99215. Even though it's a high level visit, it's 99215. That's the only office visit there. So let's go ahead and we're going to eliminate B. That's an office visit because it's missing the hospital visit. And C, that's a hospital visit and it's missing the office visit. So let's get rid of it. And that leaves us with A and D. And if you look at them, you probably don't know the difference between the two. But if you look them up, you'll see that A is coding for 99221. That's an initial visit. And D is coding for 99232. That's a subsequent visit. So let's go ahead and let's read the guideline for initial and subsequent visits. And it says, an initial service may be reported when the patient has not received any professional services from the physician or other qualified healthcare professional or other physician or other qualified healthcare professional of the exact same specialty and subspecialty who belongs to the same group practice during the stay. That's key, the stay. And I have to say that this patient did not receive any services from Dr. Milton during the inpatient stay. So this is the first time Dr. Milton has seen this patient during the stay. Dr. Milton saw them in the office, but this is the first time he saw them during the stay. So this is an initial visit. So D is a subsequent visit, and we're going to eliminate it. A is our answer. So if you got that correct, outstanding. But if you learned something, that's priceless. That's better than outstanding, right? All right, we got another scenario. Miss Tamika, please and thank you.
You are quite welcome, Mrs. J. Coders, let's dig in for scenario number 2. What is the most appropriate code for the encounter? Is it A, 99231, B, 99221, C, 99254, or D, 99222? This is a hospital visit. This is a 70-year-old female admitted last Tuesday with a cervical disc herniation. Dr. Myers asked that I come in to evaluate the patient's paralysis and numbness to affirm her symptoms are not related to a previous stroke. I had not seen this patient prior to today. A comprehensive exam and history were performed. I reviewed the patient's x-rays, CT, and MRI and concluded that the patient's symptoms are related to the patient's current diagnosis of cervical disc herniations of C5 through C7. I recommend that she undergo a cervical discectomy soon. I will see Dr. Myers today at lunch and let him know my findings. Again, what is the most appropriate code for this encounter? All right, coders, you have 2 minutes to solve. Again, please solve the scenario and place your answers in the comments or chat. Your time, it begins now.
All righty. Our time is up. How did you do? I do think you might need a little extra time. So if you will, I will give you a little more. All right. Okay, so hopefully some more people got a chance to get some answers in. Let's go ahead and highlight our key words. 70-year-old, admitted, cervical disc herniation. Dr. Myers asked that I come. Paralysis and numbness, previous stroke, a comprehensive exam, history. Reviewed the patient's x-ray, CT, and MRI, and cervical disc herniations of C5 through C7, and the patient will need a discectomy soon. All right, so again, are there any guidelines that apply? Well, I think so. That initial guideline, that initial visit is going to apply the first time a provider has seen a patient in a practice of the same specialty and subspecialty. And this patient was not ever seen by this doctor. The doctor said, I haven't seen this patient prior to today. So that's an assumption that this is an initial visit. It's a good assumption. So any scenario that you see in this presentation, when the doctor says, I have not seen this patient prior, then we're going to assume this is the first time that that doctor and that doctor in that practice has seen the patient. All right, because we don't want to be too obvious. All right. Okay. So that guideline will apply. So more than likely, this is an initial visit. Now let's get into reviewing. All right. So we see that there are initial hospital visits and subsequent visits. So we already established that this is not a subsequent visit. So we can go ahead and delete the subsequent encounter. Also, I'm getting a little ahead of myself, but I'm just telling you, if you didn't already know, this encounter does not meet the criteria for a consultation. The request, report, etc., the 3 R's, it doesn't meet it. So just let me humor you and let me tell you that C is a consultation code, so we're going to get rid of that. And there's the consultation guidance. Now, we are left with 2 codes, and both of these codes are inpatient initial visits, 99222, 99221. So the only way we'll get our answer is if we score it, right? We're going to have to score the MDM. So on the right, upper right-hand side, we're going to have to answer those questions. And let's go ahead and cross out the time because no time is documented in this encounter. So the first question, did a history and or exam take place? And yes, a comprehensive history and exam took place. Where's the location of the visit? We already established that the patient was admitted into the hospital, so we're going to say hospital. What type of visit? Is this new, initial, established, or subsequent? Well, we established that this is an initial visit. So since we're not going to consider the total time, we will determine this level of service by the medical decision making. So There's no MDM specified in the documentation, so we're going to have to do it ourselves. And we're going to inventory the diagnoses, signs, and symptoms. So the diagnoses listed: herniated cervical disc, C5 through C7, and paralysis and numbness. Now, some of you might say, well, isn't that integral to the herniated disc? It is, but it's important that you document all diagnoses, signs, and symptoms, and I'm going to show you why. But our focus needs to be the number and complexity of problems addressed. And this doctor did address this diagnosis and these signs and symptoms. So I'm going to say, no, I'm going to ask you, go ahead and type in the chat, what level of service of problems in this column right here, what level do these problems fall under? Go ahead, type your answers in the chat, and team, please shout them out if you can. I know it's hundreds of you, but you know what? We'll do our best. If you said that this is a moderate problem, and because this is one or more chronic illness with exacerbation. Absolutely. A herniated disc is a chronic illness, and it is being exacerbated by the paralysis and numbness. So it's moderate, level 4. So we're going to place a level 4 at the top. We have a level 4P. Now we're going to our data, the data column here. And where do we get our information? Well, we get it from the procedures, or what the provider did or is going to do. The provider reviewed an X-ray, reviewed a CT, reviewed the MRI, and also the provider said, hey, I recommend that this patient have surgery. So under the moderate data, it says you must satisfy one of the categories. And I believe that this data satisfies category 1. And category 1 says you have to have any 3 of the following. So we have 3 review of the results of each unique test. So this doctor reviewed 3 each unique test in X-ray, CT, and MRI. And for the sake of this discussion, CPT guideline says that if it's not separately reportable, then you can't consider it. We're going to, let's assume that all of these tests are not separately reportable. Let's just say they're skimming through, they're not actually reading, and no report for any of these have been made. All right, so we're going to do that for the sake of this discussion and the remainder of this, E&M series. All right, so we've got 3 unique tests, and that's going to be a level 4 data. Now let's get to the risk. That's pretty straightforward. This doctor recommends surgery. So, decision regarding elective major surgery without identified patient or procedure risk factors. That indeed happened. So we do have a moderate risk, level 4. So this is easy enough. All 3, the PDR are 4s. So they're all moderate risk, and that is our level. And moderate is 99222. And if you look to the right, hospital, observation, initial, moderate, 99222. And that's the answer. So if you said D, outstanding. All right. Our final scenario with Miss Tamika. All right, Miss Tamika, take it away.
My pleasure, Mrs. J. All right, coders, you guys are doing an amazing job in keeping us very, very active in the chat. So let's move along. Which code best describes the encounter? Is it A, 99232, B, 99221, C, 99231, or D, 99221? The location is the hospital. The progress note: the patient is seen today. She was transferred from observation to the floor. This is my first time visiting the patient since transferring from observation. She's essentially stabilized. She was having some type of seizure activity during the visit, however, post-ictal upon my arrival. The physical examination shows her vitals overall are fairly well stabilized. Her postoperative dressings are in place. She did have a significantly elevated INR, so the dressings have been kept in place to minimize the risk of bleeding. She was sleeping, so I didn't wake her. Her toes are pink and warm, her calves are soft. My impression is that of a seizure status post left hip bipolar hemiarthroplasty. My plan is to continue to follow, and from my standpoint, she can mobilize and weight bear is tolerated on the left side. We'll change her dressings and place TED hose on the left leg. We'll continue to follow her INR and hemoglobin. The total time of the encounter is 30 minutes. And again, which code best describes the encounter? All right, coders, you have 2 minutes to solve this scenario, and please solve and place your answers in the comments or chat. Your time begins now.
All right, time's up. How did you do? Okay, so all I could see was the chat flying. And great job, everyone. Great job. Now we're going to highlight our keywords. Patient was transferred from observation. This is my first time visiting since the patient transferred from observation. She is having some type of seizure. She has an elevated INR, and the total time of the encounter is 30 minutes. I know I was a little redundant on purpose. Now let's go ahead and let's solve. Hey, my on clicks are off. It's okay. But we have a guideline. And it said for the purpose of reporting an initial hospital inpatient or observation care service, a transition from observation level to inpatient does not constitute a new stay. So this is actually a subsequent visit. So if we look at our subsequent visit chart, The total time of the encounter is 30 minutes, and 99231 is a straightforward and or low visit. 25 minutes must be met or exceeded. So our 30 minutes was exceeded the 25 minutes, and this is our code 99231. So this was kind of straightforward. I apologize for the on-clicks, but this is our final our final part of the office inpatient or observation. And let's go ahead and review those guidelines. Number one, observation status patients are not required to be located in a designated area. The patient is classified as observation status. Number two, if an encounter spans 2 calendar dates, it is a single service unless and reported by on one date. Sorry about that. If patient is admitted to the hospital and has been seen in another site of service, such as office, ED, nursing facility, the other visit may be coded. Use modifier 25. Consultations performed on the same day in relation to an inpatient admission use subsequent hospital codes. All right, so that's very specific, and we're going to get to those consultations very soon. Prolonged service visits in the hospital observation are reported with 99418. Initial visit, use initial visit codes 99221, 99223 when a doctor or qualified healthcare professional is the first visit from the solo or group practice, and that means they have the same specialty and subspecialty during that patient's stay, during that inpatient stay. So when that's the first visit of the stay, 99221 through 99223. And I just want to point out that is not the case for consultations. And remember, physician's assistants and advanced practice nurses, they have the exact same specialty and subspecialty when working with a physician, and any physician covering for another has the exact same specialty and subspecialty as the absent physician and the same status, the same patient status. All right, so there's one more thing that I want to tell you. Don't forget, these are the guidelines, but I also want to just bring to your attention that there were some code deletions for this section. Hospital observation services, 99217 through 99220, they're gone. So those observation codes are gone. And then there's been substantial revision to codes 99221, 99223. Those are inpatient initial visits, and 99231 through 99239. So that's subsequent visits and discharge guidelines. So we're going to talk about discharging right now. All right, so we're going to begin with hospital admission and discharge on the same day. Hospital inpatient or observation care services, including admission and discharge services. This code series is used when a patient has been admitted and discharged on the same day. Now, for 2023, these guidelines have been further clarified, and you can only use the code series 992, 34, 35, and 36 when 2 or more encounters take place during that session. All right, so I'll explain it in more depth when we have our scenario, but 2 or more encounters have to take place. An initial admission has to take place, and so does a discharge in order to use that code series. However, when that doesn't occur and only one encounter takes place, you're going to have to select a code from series 99221 through 99223, and these are inpatient admission codes. All right, so let's go ahead and CHUN this section. Again, these codes are used only for when a patient admits and discharges on the same day and they have 2 or more encounters. And code 99234 is for straightforward or low-level MDM with 45 minutes must be met or exceeded. 99235, this is moderate MDM with 70 minutes must be met or exceeded. 99236, high level of MDM with 85 minutes must be met or exceeded. And for services of 100 minutes or longer, use Prolonged Services Code 99418. And pay attention, this is the inpatient code. And also be mindful that this is considered inpatient because observation and inpatient hospital have merged for 2023. Now, are you ready to test your knowledge? Okay, let's do it. Of the following codes, which best describes the encounter? A. 99235, B. 99222, C. 99221, and D. 99234. Thomas arrived at the hospital at 5 a.m. via ambulance after falling off a ladder and sustaining loss of consciousness for an unknown length of time. A comprehensive exam was carried out, then the patient was placed on observation status. The patient is now conscious and requires a concussion evaluation. Thomas remained in observation for 8 hours, after which time the physician re-evaluated the patient, advised the patient to see a neurologist for further evaluation and treatment, then discharged the patient. The physician spent a total time of 45 minutes with the patient. All right, so you have 2 minutes to solve, and your time begins now. Okay, how did you do? All right, so let's go ahead and let's highlight our key words. Comprehensive exam, loss of consciousness. Thomas remained in observation for 8 hours, and I think we have some more. Okay, there we go. And re-evaluation of the patient. All right, let's go ahead. And let's explain how we're going to get to our answer. Well, the first thing I'm going to do is pull out that guideline. This is a brand new guideline with revised language, so I need to review it. And it says codes 992, 3435, and 36. This is the code series for admission and discharge on the same day. I believe this is an admission and discharge on the same day. The patient arrived at 5 a.m. and was in observation for 8 hours, then discharged. So that is the same day. But in order for me to use this code series, two or more encounters on the same day has to take place. A minimum of those two encounters, and one for the admission and one encounter for the discharge. And if we look at the documentation, upon arrival, a comprehensive exam was carried out. Then the patient was placed in discharge status. That's one encounter. The second encounter, after the 8 hours, the patient was re-evaluated, then discharged. During that discharge period, the patient was advised to see a neurologist for further evaluation, and a total time of 45 minutes took place. So we had an initial encounter and a discharging encounter. This does meet the guideline. So on site, we can eliminate any code that's not within the appropriate code series. So code series 992, 34, 35, and 36, that is the correct one. And B and C are not in that code series. Now, I'm going to go to the front of my CPT manual and I'm going to grab the hospital inpatient or observation care services, including admit and discharge services table. Yeah, I'm going to make this easy. And then I'm going to look down for my 45 minutes at the bottom. And if I go up, my code is 99234. That's the answer. It's that simple. Yes, the key is you have to have a minimum of two encounters, and one of those encounters has to be an initial encounter and a discharge encounter. Initial visit. Now, let's go ahead and let's kind of change this up a little bit. All right, so we used this chart. It was good. Next time we're going to use the codes. I want to give it equal, exposure for this scenario anyway. All right, so we have another scenario, and this is Thomas, right? Same scenario, but Thomas was brought to the hospital at 5 a.m. by ambulance following a fall from the ladder, resulting in loss of consciousness for an unknown duration. Upon admission, that patient was placed under observation for 8 hours. You notice there was no examination. He was placed in observation for 8 hours, and everything that takes place occurs during that observation period or observation status. Now, during which time the physician monitored and evaluated the patient and diagnosed the patient with a concussion and recommended he be further evaluated by a neurologist, and the physician spent a total of 45 minutes evaluating the patient. So this is not a traditional encounter like scenario. So we're just going to walk through this together. So as you can see, there were no two encounters. There's only one encounter. As soon as Thomas arrived, he was placed in observation, then discharged. So what does the guideline say? For a patient admitted and discharged at the same encounter, that's one encounter in parentheses, see 99221, 22, and 23. So that's going to eliminate the admit and discharge codes on the same day, A and D. So let's go ahead and select our code. And we're going to use the total time. And remember, we have to select from the initial visit section, not subsequent. All right, so a total of 45 minutes means that 99221 is the correct code. This is a straightforward or low MDM with 45 minutes must having been met or exceeded. All right, so that is our code, 99221. I'm going to let that marinate. Let's take a look at same day admit and discharge guideline summary. Number 1, admit and discharges on the same day can use code series 99234, 35, and 36 as long as there are a minimum of 2 encounters, a hospital admission and a hospital discharge. And if one encounter on the day of admission and discharge takes place, if only one takes place, select codes from 99221 through 99223. Let's go ahead and talk about hospital discharges. Now, these hospital discharges, as you probably already know, are the discharges when a person discharges from a hospital or observation. And these are the guidelines. So these guidelines are straightforward, and yes, they have changed. The hospital inpatient observation discharge codes are used to report the total duration of time spent discharging the patient. That is pretty much the same. However, only the physician or qualified healthcare professional responsible for discharging services may use the discharge codes. That's new. And if they are not responsible for discharging the patient, they must use subsequent hospital visit codes. And see that little asterisk at the bottom? Please don't confuse the discharge codes. We have discharge codes, 3 different types, but this type is specifically for hospital discharges. This is when a person has stayed overnight. And these are some of the activities that are carried out during discharge. A final examination of the patient, discussion of the patient's hospital stay, instructions for continuing care to all relevant caregivers, preparation of discharge records, prescriptions, and referral forms. So these are some of the activities that are carried out during discharge. Now, let's go ahead and let's CHUN our discharge codes. And these are, again, hospital inpatient or observation discharge services. And I like to put a box around that discharge services just to let me know that this is the only thing that's happening. This is not admit and discharging. All right, so 99238 is the code for hospital inpatient or observation discharge day management, 30 minutes or less on the date of the encounter. 99239 is more than 30 minutes on the date of the encounter, and you see how I've documented, and pay attention to the notes at the bottom. Your parenthetical guidelines say for hospital inpatient or observation care, including the admit and discharge on the same day of the patient, use code series 99234, 5, and 6. And newborns admitting and discharge on the same day, use 99463. So we're not talking about that, and that's why they brought that to your attention. We are talking about hospital discharging. All right, I'm going to let that marinate for a moment or two. Now, are you ready to test your knowledge? I know you are. All right, Miss Dolly, take it away.
Thank you, Mrs. J. All right, coders. Of the following, which codes best describe the visit for the discharging physician? A, 99239, B, 99238, C, 99234, or D, 99232. Discharge disposition. A patient involved in an automobile accident the week prior sustained bilateral fractured femurs. Anxious to discharge, the patient asked the nurse to request that his physician expedite his discharge, or he would leave on his own volition. The discharging physician was doing rounds and was unavailable at the time of request. However, his colleague from another practice, already on the floor, agreed to carry out the discharge. The total time spent performing discharging services was 40 minutes. Of the following, which codes best describe the visit for the discharging physician? Okay, coders, you have 2 minutes to solve, and your time will begin now.
All right, time's up. How did you do? Hopefully, you knocked this out the park. I know you did. I just know it. All right, my keywords. I only have two: bilateral fractured femur. Discharging services was 40 minutes. That's all I have. Now, it's time to apply a guideline. What are the guidelines when it comes to discharge? Well, it says that these discharge codes, 99238 and 39, can only be used by the party who is responsible for the discharging services. And I look up, the discharging physician was doing rounds and was unavailable at the time of a request. However, he asked his colleague from another practice already on the floor, and I think this was done emergently because the patient was going to go. So this doctor who did the actual discharge did not have the authority. So the guideline says that the non-discharging physician has to use subsequent visit codes. So if we look at the hospital subsequent inpatient codes for a 40-minute encounter, it falls within 35 minutes that must be met or exceeded. It doesn't meet the 50 minutes. So 99232 is our answer, and that is D. Now, A is incorrect because it is a discharge code, a regular hospital discharge code, and so is B. And C is incorrect because it's admit and discharge on the same day. So if you said D, outstanding. Now let's go ahead and review the guideline summary for discharges. So the first one is hospital, inpatient, or observation discharge service guidelines only apply to the provider or practice responsible for discharging the patient. So those are the ones that can only use those codes. Hospital, inpatient, or observation discharge codes are used to report the total duration of time spent discharging the patient. And number 3, doctors and qualified healthcare professionals not responsible for discharging use subsequent hospital visit codes. Now, it's time to talk about consultation visits. Yes, it's all green too. That means that a lot of revision has taken place. So let's get started. So at the top, it says a consultation is a type of evaluation and management service provided at the request of another physician, other qualified healthcare professional, or appropriate source to recommend care for a specific condition or problem. That appropriate source, that's new. So, who isn't appropriate? Well, the very next, the third paragraph down, it says a consultation initiated by a patient and or family is not reported using consultation codes. So that is not an appropriate source. But they do list that non-clinical social workers, educators, lawyers, and insurance companies, these are considered appropriate source. And consultations can be coded if a request by an appropriate source took place. A consultant may recommend treatment or provide a diagnosis and or opinion. A consultant must provide a written report to the requester. Now, as you can see, let's go ahead and find these guidelines. It says a physician or other qualified healthcare professional consultant may initiate diagnostic and or therapeutic services at the time of the subsequent visit. That's your recommend treatment or provide a diagnosis and opinion. The consultant's opinion and services that were ordered or performed must also be communicated by written report to the requesting physician, other qualified healthcare professional, or other appropriate source. It doesn't say that they have to document in their file or chart. It says they have to write back to the requester. So the 3 R's: request by an appropriate source. And when I say appropriate source, a doctor, qualified healthcare professional, and what they define as an appropriate source, recommendations, and a report back to the requester. And remember, a consultation may not be requested by a patient or family member. So these guidelines are similar, but they have definitely been revised. Now let's get to consultations as they pertain to hospital visits. All right. So the first paragraph at the bottom, in the case when the services in a separate site are reported and the initial inpatient or observation care service is a consultation service, do not report 99221, 222, 223, 99252, 99254, or 55, and I missed 99253. These are all initial visits. Initial visits, initial consultations. You cannot report an initial consultation, and I'm going to clarify it here on the left. If a consultant has already seen patient at a separate prior location and then sees the patient again in the hospital, and that hospital visit is an initial hospital visit, do not code initial visits, use subsequent hospital inpatient observation visit codes. All right? So subsequent visits. And some people might say, well, why is this necessary to say? Because if the visit prior, any visit prior, we just coded our very first scenario. We had a visit with a office visit. We had an admission in the setting of an office visit. So this consultation encounter kind of contradicts it. So, it might take a little bit to comprehend, but if a consultation occurred prior to an admission, that admission, if the consultant visits in the hospital, that visit will be a subsequent hospital visit. Also, here's another guideline. It says if a consultation is performed in anticipation of or related to an admission by another physician or other qualified healthcare professional, and then the same consultant performs an encounter once the patient is admitted by the other physician or other qualified healthcare professional, go ahead and report the consultant's inpatient encounter with the appropriate subsequent care code 99231, 2, and 3. This instruction applies whether the consultant occurred on the date of the admission or a date previous to the admission. It also applies for consultations reported with any appropriate code, such as office or other outpatient visit, or office or other outpatient consultation. So that was a mouthful. All right, so we clarified it. Hopefully, when a consultation is carried out on the same date or any previous day of a related admission, If the consultant visits that patient in the hospital, code the first consultation, and the hospital visit is also coded as a subsequent hospital visit. Now, I hope that makes sense to you. And if it doesn't, maybe you'll get this. This is a visual. So let's start with that first guideline. We're going to code for Dr. Brown, right? Dr. Brown has a cardiology consult. That means that the 3 R's were met with Mr. Lewis in his office. Then Dr. Brown says, hey, Mr. Lewis, something's not right. Let's go on over to the hospital, right? So he goes on over to the hospital, and then Dr. Brown carries out a consultation with Mr. Lewis in the hospital. So how do you code it? Well, this guideline up here says that you code the office consultation. You also code the visit as a subsequent hospital inpatient visit. So in the case where the services in a separate site are reported and the initial inpatient or observation care service is a consultation, do not report 99221, 2, 3. Don't report the consultation, initial consultation 99252, 3, 4, 5. The consultant reports the subsequent hospital, inpatient, or observation care codes for the second service on the same day. Now, that other guideline, let's say Dr. Brown has a cardiology consultation with Mr. Lewis in his office. Dr. Brown sends Mr. Lewis to the hospital. And then Dr. Lee evaluates Mr. Lewis and admits the patient. Then Dr. Brown visits Mr. Lewis. Let's say he just visits him. Let's say he does a consultation or anything. Anything this doctor does in the hospital will be a subsequent inpatient or observation visit. All right. So it's very specific to consultations. Consultations can't be, you can't have a follow-up consultation. That seems familiar, right? Yeah. So those are your guidelines. Hopefully that makes sense. Now let's go ahead and take a look at the CHUN. Consultations, code series 99242 through 99255. All right. These are, and there's some guidelines too. These are for the new and established patients. In other words, these are outpatient consultations. These are used for consultations in the home, the office, or the ED. Those are some examples. And any follow-up visits, use subsequent visit codes. Okay. Transfer of care, use new visit codes if transfer of care is applicable. But from what I was reading, it's been eliminated, but I don't know why that's there. But if it is a transfer of care, use new visit codes. All right, so just know that 99241 has been deleted and you are directed to report 99242. 99242 is the office or other outpatient consultation for a new or established patient, and this is a straightforward medical decision-making encounter. 20 minutes must be met or exceeded. 99243, this is low level of MDM. 30 minutes must be met or exceeded. 99244, moderate level MDM. 40 minutes must be met or exceeded. And finally, 99245. This is high level of MDM. 55 minutes must be met or exceeded. Now we've gotten the office out of the way. Let's go ahead and look at the inpatient or observation consultations. Oh, I do want to point out at the top, when you have an outpatient consultation requiring prolonged services, use 99417. Now let's go ahead and CHUN inpatient. For an inpatient or observation consultation requiring prolonged services, use 99418, and 99251 has been deleted, and go ahead and use 99252. 99252 is a straightforward MDM. 35 minutes must be met or exceeded. 99253 is a low-level MDM, and 45 minutes must be met or exceeded. 99255 is moderate-level MDM, 60 minutes must be met or exceeded. And finally, 99255, this is high-level MDM, 80 minutes must be met or exceeded. And for 95 minutes or longer, use prolonged services code 99418. All right, so we've got the CHUN out of the way, so now it's time to test our knowledge. And Miss Dolly, please and thank you.
Thank you again, Mrs. J. Okay, coders, of the following, which best describes the encounter? A, 99243, B, 99253, C, 99254, or D, 99255. A 33-year-old male patient was admitted after prophylactic bilateral mastectomy. Patient is positive for BRCA1 gene mutation. The patient was otherwise healthy until pathology indicated cancer with metastasis. Labs and studies reveal an elevated PSA. Dr. Vaughn was requested by Dr. Bellinger to evaluate the patient for possible secondary prostate cancer. Dr. Vaughn carried out a moderate history and exam at patient bedside, ordered a CT scan of the prostate, and a transrectal ultrasound with biopsy. The patient's PSA was ordered to be retested. Then Dr. Vaughn sent correspondence to Dr. Bellinger that the patient had a diagnosis of prostatitis. The patient was treated with 400 milligrams of Floxin every 12 hours orally. Of the following, which best describes the encounter? Okay, coders, you have 2 minutes to solve, and your time will begin now.
All right, your time is up. I hope you did well. I know this was longer than most. You probably needed a little more time. So just kind of, you know, kind of follow along if you can. We have a 33-year-old prophylactic bilateral mastectomy, BRAC1 gene mutation, cancer with METs, elevated PSA, requested by Dr. Bellinger, secondary prostate cancer, moderate history and exam, ordered a CT scan of the prostate, a transrectal ultrasound with biopsy. PSA was ordered to be retested. Dr. Vaughn sent correspondence to Dr. Bellinger with a diagnosis of prostatitis and treated the patient with 400 milligrams of Floxin. All right, so I guess since we are talking about consultations, we have to determine if this meets a consultation, but we'll do so when we answer the questions in the upper right here. And was a history and or exam carried out? Yes, there was a moderate history and a moderate exam, so we're going to say yes. Where was the location of the visit? Now, somebody might say, well, the hospital. Absolutely. The physical location was in the hospital, but I'm talking about the location in the CPT manual. So what type of visit is this? Well, a request by Dr. Bellinger was made. A diagnosis of prostatitis was rendered, and a written report was sent back to Dr. Bellinger by Dr. Vaughn. So this does meet the definition of a consultation. So the location of this visit is an inpatient consultation because it meets the 3 R's. Now, what type of consultation is this? Well, all consultations are initial, I mean, you don't have a subsequent consultation. We already talked about that. And there is no total time documented, so we are going to eliminate that. And we're going to determine the medical decision making because that also was not provided. So we're going to have to score the documentation, and we're going to do that by inventorying first. We're going to document our diagnoses, signs, and symptoms. So the diagnoses that we have are BRAC1 gene and prostatitis. All right, so which level, if we go to the problems and we talk about the problems addressed, I'm looking over, were both of these problems addressed? If you said no, very good. The BRAC1 gene was not addressed. This doctor is likely a urologist, and they came in to do a consult on the condition of the prostate. So prostatitis was definitely addressed by this consultant. So we have one, what do you think it is? Level 2, 3, 4, or 5? Well, if you said level 3, outstanding, here's why. Because prostatitis is a stable illness. So it could be, it is an acute illness. So it could be an acute, uncomplicated illness or an acute, one stable acute illness, either or. And that's what I'm sticking with. Prostatitis is inflammation of the prostate, and this is indeed acute because if you think about how prostatitis can occur, it can occur with an infection, an injury, or some type of immunity disorder. So prostatitis is an acute illness. So therefore, our problems are a number 3. Now let's go ahead and talk about the data. So what procedures took place, or what did the provider do, or what are they going to do? So this provider ordered one CT scan, one PSA was reordered, or excuse me, retested, and then we ordered an ultrasound and also a biopsy. So I think this meets category 1. In this data section, under moderate data, level 4, category 1, and it says any 3 from the following. So this provider, Dr. Vaughn, ordered a unique test, 3 unique tests. So level 4 it is for me. Now the risk, well, even though a biopsy took place, Dr. Vaughn prescribed 400 milligrams of Floxin, so prescription drug management took place, and the score for the risk is level 4. So since the problems, the data, and the risk are not the same, you have to have the same PDR, and since our PDR has one different one, we have to level. And how you level? You have to throw out the lowest level, and that's found, and 3 is the lowest, so we have to eliminate our P, and that leaves 4, and that is our level. And if you look over on the right column, consultations, inpatient, 99254. That's our answer. And C is it. All right. So I think it's time for another scenario. And I believe that we have a change. Am I correct?
Mrs. J, is this me reading?
It is. I apologize. All right. Welcome back, Miss Dolly. Take it
All
away.
right. Thank you, Mrs. J. Okay, coders, which of the following best describes the encounter? A, 99202, B, 99252, C, 99221, or D, 99231. A 79-year-old inpatient at Mercy Hospital was admitted with a diagnosis of Streptococcus pneumoniae that evolved to septic pneumonia. The patient's family believes the patient contracted sepsis while in the hospital. The family located Dr. Mitchell on Google and asked that he evaluate the patient. The doctor carried out a medically appropriate exam with low MDM. Dr. Mitchell reviewed the patient's Streptococcus pneumoniae antigen, urine, and cerebrospinal fluid results, and confirmed the patient's diagnosis of septic pneumonia, then notified the patient's PCP via Epic of his findings. Dr. Mitchell told the family that he could not determine how the patient contracted sepsis. Which of the following best describes the encounter? Okay, coders, you will have 2 minutes to solve, and your time begins now.
All right, time's up. How did you do? Hopefully, you knocked this one out the park, and hopefully, you're starting to get these guidelines down. I know you are. All right, our keywords: 79-year-old, inpatient, Streptococcus pneumoniae, septic pneumonia. Dr. Mitchell was found on Google and asked to evaluate the patient. The family asked. Also, a medically appropriate exam was carried out by Dr. Mitchell with low MDM, and Dr. Mitchell reviewed the patient's records, the Streptococcus pneumoniae antigen, the urine and cerebral spinal fluid results. The septic pneumonia was confirmed by Dr. Mitchell. Now, coders, is this a consultation? Go ahead, type your answers in the chat. All right. Well, let's just go to the guideline. The guideline says a consultation initiated by a family member or the patient is not reported using consultation codes. So we're going to have to say, no, Dr. Mitchell was found on Google by the family. Again, you need 3 R's: a request by at least an appropriate source, and the consultant may make recommendations, and that consultant has to report back to the requester a written report. So B is incorrect. That's 99252. That's a consultation code. So take a look. This is the consultation. Oh, wait, I thought I had it, but guess not. So let me go ahead and indicate what these codes are. 99202 is a new office visit. 99252 is an inpatient consultation. 99221 is an initial hospital visit. And 99231 is a subsequent hospital visit. We know this patient was in the hospital because they were admitted. So let's go ahead and look at the inpatient guidelines for initial visit. And it said pretty much this is the, you can use the initial visit codes for the first visit by any member of a group practice per stay, and subsequent visit by any member of a group practice, any subsequent visit by any member of a group practice. And these are your inpatient consultation codes, and just want you to see them. They are not applicable because no consultation took place. So here are the inpatient visits, initial or subsequent. Well, this is an initial visit because Dr. Mitchell has not seen this patient before. Remember, Dr. Mitchell was found on Google, and it's highly likely they have any relationship with Dr. Mitchell. So we're going to code this as initial 99221 because 99231, that's your subsequent. So the answer is C. And if you got that correct, outstanding. Now let's go ahead and look at the consultation guideline summary. Number 1, a consultation must have the 3 R's: request by at least an appropriate source, recommendations of treatment, diagnoses, must provide a written report to the requester. So that consultant has to provide a written report. And a request made by an appropriate source and report are mandatory. So I'm saying 3 R's, but actually you need a request, at least by an appropriate source, and that report back to that requester is mandatory. A consultation may not be requested by a patient or a family If a consultation takes place on the date of admission at a separate site, report subsequent hospital codes. If if the consultant has seen the patient prior to admission to the hospital, even if that admission was by another doctor, and that consultant also visits the patient in the hospital, report the first visit at the other site and a subsequent hospital visit for the hospital visit. If a consultation is carried out after another doctor admits the patient, report subsequent inpatient hospital codes. Prolonged services codes for inpatient consultations, use 99418 and codes 99252 through 99255. These are inpatient consultation. They may be reported only once per consultant per admission of a patient who is in the hospital, inpatient or observation status. Now let's take a look at consultation section code deletions. Well, you know 99241, that's your office consultation, that was deleted. So too was 99251, that's your inpatient consultation. And then you had significant revision of consultation codes, 99242 through 99245. Also 99252 and 99255. All right, so now let's talk about emergency or ED guidelines. And emergency departments must be hospital-based and open 24 hours a day. Another guideline is if critical care on the same day as the emergency department visit, code only the critical care. If observation status, admit and discharge on the same date as an ED visit and nursing as well, do not code the ED visit, code separately reportable E&M services when a patient is admitted into the hospital, such as an office visit. You can code that ED, right? You can code the ED from and when they are admitted into the hospital. And finally, patients seen in the ED for the convenience of a doctor or qualified healthcare professional, you do not code it as an ED, you code it as an office visit. Okay. All right. So now let's go ahead and CHUN the Emergency Department Services Code Series 99281 through 99288. I didn't know it was that high. 88? All right. Now let's go ahead and code or CHUN Emergency Department Visits Code Series 99281 through 99285. It says 88. Let's see if it'll change. Let's see. Okay. Well, you know that's an 85. All right. I'm just going to put them all here. 99281 is the code for clinical team, such as a nurse, an RN visit in the ED. It does not require the presence of a physician or a qualified healthcare professional. So 99281. 99282, this is a straightforward MDM. 99283 is low-level MDM. 99284, moderate MDM, and 99285, high MDM. And just want to point out, These codes are not based on time. Are you ready to test your knowledge? If you are, the next voice that you will hear will be Miss Jasmeet and Mr. Sandeep. Take it away.
All right, thank you so much, Mrs. J. I'll read the scenario for you, Mr. Sandeep. Subjective. A 32-year-old female who presents to the urgent care for the first time with chief complaint of increased post-operative swelling. This patient had a right neck lymph node biopsy done 3 days ago. Patient had a dressing in place ever since then. For the past 24 hours, she feels like she has increased swelling and she presents now because of it. She denies any accompanying fever, chills, or sweats. The physician carries out a moderate history and exam with moderate MDM. The patient was diagnosed with a mild post-operative infection and was prescribed amoxicillin and directed to keep the area clean. Which of the following best describes the encounter? The options are A. 99214, B. 99284, C. 99204, and D. 99283. Sorry about that. I should have read the options before I read the scenario. But coders, you have 2 minutes to solve the scenario, and thank you.
So, coders, that's 2 minutes. And thank you, Ms. Jasmine, for reading the scenario for us. Thank you, Mrs. J. So, coders, let's go ahead and solve the first scenario under emergency department. Let's highlight the keywords: a 32-year-old, urgent care, first time, increased post-operative swelling. There was a moderate exam, moderate MDM performed, and an amoxicillin is also prescribed. So, Chorus, I want to ask you a question. What do you think the location of this particular service is? Do you think this is going to be an emergency department visit? If you look forensically, you will find that this is an urgent care encounter. An urgent care encounter are different from emergency department encounter. So we are not going to give the ED codes. Yes, non-ED visits may not use ED codes, and these emergency codes are ranging from 99281 to 99285. So right away we are going to eliminate option B and D because these two codes are for emergency department, and the remaining two codes are option A and option C. You can see the option A is coding for an established visit, and option C, it is coding for a new patient visit. Now next job of ours is to select the best, not the best, the correct from option A and C. And if you have a look into the documentation, it states that this is a first visit, first time with the patient. So this is going to be a new patient encounter and not an established. Well, that eliminates option A. Still, we have to go and check the table and see where does the MDM lies. And you can see the moderate, and it is coding for 99204. And our correct answer for this first scenario on the emergency department is going to be option C, 99204. So how are you doing, coders? I see some people got tricked by the urgent care, so they are different from emergency department. So that's the first scenario, and let's see whether we are having next one. Okay, Miss Jasmine, you can take the next scenario as well.
Thank you so much, Mr. Sandeep. Um, Of the following, which best describes the encounter? A. 99221, B. 99284, 99221, C. 99222, 99284 with the modifier 25, and option D, 99232 and 99284 with the modifier 25. Subjective. This is a 39-year-old female presents to the ED after giving birth at the birthing center. The doula recommended that the patient be seen because she remained febrile after the birth. During the ED encounter, physician carried out a moderate history and exam with moderate MDM. The physician was unsure of the etiology and decided to admit the patient for testing. A medically appropriate exam was carried out with moderate MDM. The patient was diagnosed with retained products of conception and a D and C was performed. Coders, you have 2 minutes to solve the scenario. Thank you.
And coders, that's 2 minutes. And thank you once again, Ms. Jasmine, for reading the scenario. So, coders, from what I see in the chat, you guys are really nailing the evaluation and management guidelines and all these scenario. Fabulous work, coders. So, let's highlight the keywords. A 39-year-old female ED after giving birth, and we are having a moderate history and a moderate exam as well, which is performed in the ED along with a moderate MDM, followed by patient is admitted. The physician is admitting the patient, and later on he is also performing a medically appropriate exam with a moderate MDM as well. And finally, the diagnosis is a retained product of conception for which a DNC was performed. Okay, how are we going to solve this scenario? We are going to follow the emergency department guidelines, which states that to report the services when the patient is admitted to the hospital, inpatient or observation status, or to a nursing facility in the course of an encounter in another settings, see initial hospital, inpatient or observation care, or initial nursing facility care. So we are having two encounters over here, like the patient was in the ED followed by an admission as well. So following the hospital inpatient or observation guideline, it states that when the patient is admitted to the hospital as an inpatient or observation status in the course of an encounter in another site of services, the services in the initial site may be reported separately, and we are going to use a modifier 25 along with it. So we are having two encounters here, one which happened in an ED and one which is an inpatient encounter. So as per the hospital inpatient guideline, we are going to code for the both encounter along with the 25 modifier. So with that in mind, I think I can eliminate option A and option B, because as I said, we are going to have two sets of codes here, evaluation management codes, and option A is not satisfying that. So option A is wrong, and option B is also wrong because it is also not using a 25 modifier, right? Because the hospital inpatient guidelines states that we have to use a 25 modifier along with these E&M codes. So option B is also wrong. And let's move on and let's pick the correct between option C and D. So for that, we are going to answer the questions which we are having. Is there a history and exam? Yes, there is a moderate history and exam as well, and a medically appropriate exam and an exam as well performed in the inpatient. So next question comes the location of the visit. You can see we are having an ED encounter and an admission as well, which will be under inpatient encounter. So we are having two encounter here, hospital inpatient and ED. Next, the type of visit new or established. You can see that it is an initial encounter here. And the fourth point, total time of the visit. Well, there's no time documented, and then we are going for the medical decision making, isn't it? And the medical decision making in the emergency department is moderate, and in the inpatient encounter as well as it's a moderate medical decision making. So overall medical decision making is going to be a moderate one. And next, let's have a look into the code series which we have. So we have seen that it's a moderate MDM which we are having for the emergency department, and it comes under the code 99284. And for the initial hospital care or observation care, the moderate MDM falls under the CPT code for 99. Let me have a look into it. 99222. So the correct answer for this scenario is going to be 99222 and 99285 with the 25 modifier. So good work, coders. You have done a great job here. So that's all from scenarios from my side, Mrs. J. Do you want me to go through these guidelines as well?
Absolutely. Thank you.
Thank you. So coders, we will just review the guidelines of emergency department, which we covered here. The ED must be a hospital based and open for 24 hours a day. If the critical care on the same date as ED, code only for critical care, and if observation status, admit and discharge on the same day, nursing facilities do not code as ED. Fourth point, code separately reported code separately reported E&M services. And the fifth, the patient seen in the ED for the convenience of another doctor or qualified healthcare provider, code as office visit. And the sixth point, the site of the service may not solely determine the appropriate code to report. For example, when critical care service are provided in the ED, it's an example for which we will be going and coding for critical care services. So 7 point, patient seen in the ED for the convenience of physician should be reported with office visit codes. And the last one, reporting additional services or procedures with ED services are permitted. Use the appropriate modifiers. So that's an emergency guideline summary for you.
Thank you. Wow, great explanation, Mr. Sandeep. And I want to end this section kind of going ahead of me. Let's see. The emergency section code deletions or revisions. There's a revision of the ED services code series 99281 through 85, and those guidelines have been highly revised.